Thanks for listening to the Pharmacy Podcast Network.
You're listening to the NASP Specialty Pharmacy Podcast, a collaboration between the National Association of Specialty Pharmacy and the Pharmacy Podcast Network. Each episode dives deep into trends, challenges, innovations, and patient-centric practices shaping the future of this dynamic and rapidly evolving industry. Whether you're a pharmacist or healthcare provider, patient advocate, or industry leader, you'll hear expert insights, real-world evidence, and thought-provoking discussion that highlights all that makes specialty pharmacy special.
In support of NASP's mission to empower specialty pharmacy stakeholders to advance the standard of patient care, NASP supports a free market healthcare system in which all specialty pharmacies compete on the same fair and level playing field, because that is in the best interest of the patients we collectively serve. NASP is committed to working with all stakeholders and policymakers to ensure that all patients have access to the life-saving medications they need and the high-touch patient care and support services they deserve from the pharmacy of their choosing.
Hello, my name is Sheila Arquette, and I'm the President and CEO of the National Association of Specialty Pharmacy. I'm delighted to welcome my special guests, Marina M. Carter, PharmD, BCACP, and Dan Landup, PharmD, HF-Cert, to this episode of the NASP podcast, brought to you in partnership with Pfizer. Marina and Dan are going to share their experience identifying patients with ATTR CM and the expanding role of clinical pharmacists in patient identification, collaboration with multidisciplinary care teams, and the use of tools such as the EHR to support proactive care. After earning both undergraduate and pharmacy degrees from the University of Kansas, Marina Carter completed an ambulatory care residency at Prisma Health in Columbia, South Carolina. Following residency, she joined Prisma Health Cardiology as an ambulatory clinical pharmacist, contributing to outpatient cardiology practices. Recently, she relocated to Roanoke, Virginia, where she currently serves as a clinical pharmacy specialist in the Advanced Heart Failure Clinic at Carilion Clinic. Her clinical interests include heart failure, cardiac amyloidosis, increasing access to care in rural settings, and hyperlipidemia. Dan Landup is a clinical pharmacist specializing in heart failure and cardiology. Dr. Landup received his Doctor of Pharmacy degree from the University of Illinois Chicago Rutsky College of Pharmacy in 2012. Upon graduation, he completed a PGY1 pharmacy residency and a PGY2 specialty residency in cardiology pharmacy at UIC. Dr. Landup currently operates a pharmacist-managed outpatient heart failure clinic within Advocate Medical Group, where he has practiced since 2015, caring for patients with chronic heart failure, including patients with ATTR CM. In addition to his clinical role, Dr. Landup has given numerous presentations on various topics involving the management of patients with heart failure. Marina and Dan, thanks so much for joining me today.
Glad to be here.
Absolutely.
So to start off with, what led to the involvement of clinical pharmacists supporting patient identification?
For me, it really started with a personal interest. I've always been fascinated in how this disease eludes many clinicians. I do remember looking back and realizing how many patients were sitting right in front of me in my own heart failure clinic that had ATTR CM or cardiac amyloidosis. And not only did I not suspect it, but I did not even consider it as a potential cause of their heart failure. This is unfortunate because you have a patient with a life-threatening condition for which we now have treatment options, but in order to treat it, you have to diagnose it. And in order to diagnose it, you have to identify it. And in order to identify it, you must suspect it. In this case, clinical suspicion is key. With me working in a heart failure clinic, I realized that I am the ideal person to do this since I see these patients frequently. And so over time, I started to focus more on identifying patients that may have cardiac amyloidosis.
I completely agree with Dan. We had the similar setup in our clinic as well, where these patients were just being unidentified for multiple visits in a row. Something unique about my practice is it's typically in the rural health setting where access to primary care is already limited. And so we're kind of functioning as a lot of different pieces of the puzzle for these patients. And so that's where we were kind of involved in just all hands on deck a little bit in our clinic.
Dan and Marina, from your experience, what is the impact on the diagnosis timeline when a clinical pharmacist is involved in the multidisciplinary team?
So as I mentioned earlier, clinical suspicion is key, but also the timeline in diagnosing these patients is key as well. If you look at the data, very few patients are diagnosed in a timely fashion. We see patients often see multiple providers before getting the correct diagnosis. Less than half of patients actually get their diagnosis within 6 months of their symptom onset. And if you look at some of the studies out there, there's a mean delay of about 6 years since the symptoms manifest until the patient gets the correct diagnosis. So the importance of early diagnosis can be underemphasized. You really have to look at those clinical clues, especially those clues that come up years before the patient even develops heart failure. So carpal tunnel, for example, patients often get that 5 to 10 years before any heart failure symptoms become apparent. Likewise with lumbar spinal stenosis, some of the other manifestations. And if you look at the treatment options and the effects of treatment, they're most pronounced when you can get these patients identified early. All of our disease-modifying treatments, they cannot reverse disease. They can only prevent disease progression. Having a pharmacist on board, someone who is looking at these patients frequently, is key. If you're the difference between identifying the patient now versus a year down the line, you made a significant impact in how the effects of treatment will be for that patient. So clinical suspicion is crucial, but also timeline in how fast these patients are diagnosed is also critical as well.
I think a good role for the pharmacist on the team is the access to us in the clinic. So using our collaborative practice agreements, we can see patients every 2 weeks or every 4 weeks because our schedules tend to be a little bit more flexible with that. And so we can see these patients sooner or get them in for labs sooner, workup pieces sooner. And so that's a huge way that we can make an impact on the timeliness of diagnosis. So getting those AL rule-out labs at the PharmD visit instead of waiting till their 3-month follow-up with the providers is one way to do that. Another way is to help increase education among the other specialties that might see these patients before they even come to our clinic. So specialties like neuro and ortho, who might be working these patients up and doing these carpal tunnel surgeries or doing these stenosis visits, and helping them identify patients sooner to then get them looped into our clinic sooner, help with the diagnosis, and get that faster than what it traditionally has been.
Is this like a progressive type disease where you would have this amyloidosis, like when, like you're a younger person and it starts out and now you start to see some of these deposits? So hence like the stenosis and the carpal tunnel, but you don't necessarily develop heart failure until later on in life?
Yeah, I mean, it's quite fascinating, actually. So you're correct. So it's a diagnosis of, late age males predominantly, so 7th to 8th decade of life. But for example, patients who have the variant form, they'll have a genetic mutation, they're born with it, but it takes time, depending on which mutation you have, for it to manifest as heart failure. And interestingly, the penetrance is incomplete. So you can have a patient who has a genotype, but will never develop the phenotype of cardiomyopathy. But yes, it is progressive. Once you get it, those deposits continue to deposit in the heart, and ultimately it's fatal. So this is why catching it super early, if you can, get patients in treatment.
I feel like a lot of historical data has always called it senile amyloid or senile cardiomyopathy because it happens so late in life that the cardiac manifestations would come. But obviously now that we're screening more patients and we are increasing access to care, that's obviously a lot better.
Yeah, I love that. Oh, thank you so much for answering that. That's pretty cool. So what clinical factors are you evaluating when you're identifying patients who may have ATTR CM?
Honestly, any patient that receives a diagnosis of heart failure, especially heart failure with a preserved ejection fraction or HF-Pef, as we call it, should have amyloidosis at least included as part of the differential. We now see that ATTR CM, the most common form of amyloidosis, can be identified in up to 20% of those patients with heart failure. In my practice, I tend to screen all patients for the musculoskeletal manifestations.
What are those, Dan? What are those?
So common ones are lumbar spinal stenosis, which some of the data shows that can be seen up to 1/3 of patients with amyloidosis or ATTR CM specifically. Lumbar spinal stenosis, there's a study where they took patients who had stored specimens, no heart failure symptoms, no cardiomyopathy, said, hey, free of charge, we'll get your specimens tested, and 33% was positive for amyloid. So
Wow.
1/3 of patients undergoing, they often call it now carpal tunnel of the spine. So it's definitely not uncommon. It's just we still don't know, okay, you caught it in the spine. What do you do then? So right now, there's no treatment options for those patients until you develop heart failure.
Yeah.
So we typically just, trend, get echocardiograms every few years and then kind of just follow the patient to see if they actually develop symptoms. But then you'll be 10 steps ahead because now you can look out for it prospectively and then catch it again earlier since you know about it. Another one is carpal tunnel syndrome. So about 7 to 8% of patients with carpal tunnel will have actually amyloid deposits in the tissues at the time of their biopsy. Others include a biceps tendon rupture or a history of a hip or a knee replacement. So I will often use the search feature in Epic and type in these conditions to see if any of those conditions are identified in the patient's record. After that, I will also look at the echo in detail. So most pharmacists, when they're learning to work in a heart failure clinic, are taught to look at the ejection fraction. However, for amyloidosis, you really have to go beyond EF. So I will look at the wall thickness on the echocardiogram, the global longitudinal strain, which also measures how the heart's pumping, and there's a specific strain pattern that we can see that can be suggestive of cardiac amyloidosis. If the patient has a cardiac MRI, that's also very useful, but most patients actually don't have that prior to their diagnosis. So it's really the extra cardiac clues along with the echo that makes me think this patient may have ATTR CM. There's a 6-variable clinical score that was developed by the Mayo Clinic that can be also used to identify patients with a higher pretest probability of having ATTR CM. So clinicians can use this score to justify the need for further testing. But where I really think the future is using AI algorithms, machine learning that can scan the patient's record more efficiently, look at some clinical clues in the diagnostics, and then better identify those patients that may have the disease, because again, it is very frequently under-recognized and disease awareness is getting better, but it's still poor among clinicians.
Yeah, I agree with Dan completely on all of those factors. Another thing we like to look at is the genetic testing side for the hereditary ATTR CM, and making sure that family members of patients that are testing positive are getting the cascade testing after that. We have been able to identify multiple family members for families that tested positive and could potentially be screened sooner or started on therapies to prevent the progression of the disease as well. So making sure that we're following up on the genetic testing side of it as well.
So what hurdles do you have to navigate along the way? For example, building trust amongst multidisciplinary team members or technology concerns?
I mean, the main hurdle with us was making sure that our collaborating providers were all comfortable with the pharmacist initiating the workup for a patient. We know that this workup involves labs and tests that many clinicians are not familiar with, especially when it comes to ruling out the other form of amyloidosis, light chain amyloidosis, which is actually the first and most critical step. And I needed to make sure that our providers who we work with were agreeable with us in doing this for our patients. Another hurdle we had was the standardization in our PYP testing. We have several sites. We're a large organization that performs this scintigraphy test with several different readers, including both cardiologists and radiologists. And when we first started screening more and more patients, we realized there were inconsistencies in how these tests were performed at the various different centers, how the exams were being read by the specific reader, and what was reported in the interpretation. Similar to this, we had for some insurance plans run issues into insurance not covering the PYP scan itself. And so for those patients, we even had to discuss with their insurance plan to get the test authorized, which at times did require a peer-to-peer review in order to get that scan covered for our patients.
And another hurdle that we had as well is just the role of a pharmacist in a clinic. So that's kind of newer. in practice, especially in settings where there's not an academic institution around to have a role model of what that should look like. So getting rapport with patients and building trust with patients as well as the multidisciplinary team is a huge hurdle. Trying to help the patients understand why they need to see the pharmacist and what our role is in their care. And additionally, some hurdles with just access to care, getting patients to and from appointments, getting their appointments scheduled. In some settings, the PYP scan might have to be at a larger institution, which could be 1 to 2 hours away from where they live. So those are other barriers and hurdles that might come up with the workup.
Wow. Can you explain a little bit about what is a PYP scan? I mean, is that involved or is it something like an X-ray?
Yeah, so a PYP scan it's a nuclear study, but it actually was first used to diagnose myocardial infarctions, back before I was even born. But then we found that for patients with amyloid, these PYP or technetium pyrophosphate, it tends to bind to these amyloid fibrils in the heart.
Mm-hmm.
So if you look at back in the day, every patient with suspected cardiac amyloidosis required myocardial biopsy. The first study that looked at disease-modifying therapy, that was the inclusion. You had to have ATTR CM diagnosed by a biopsy.
Thanks.
Then we realized this test can identify these patients. And as long as you exclude the monoclonal proteins for the light chain amyloidosis, the other rare, more severe type, if this test is positive, it's a grade 2 or 3 uptake on the scan is positive, you have 100% positive predictive value for ATTR CM. So nowadays, about 85 to 90% of patients can be diagnosed non-invasively with this method. And that's crucial for us because to get an endomyocardial biopsy, you only have to refer to the cardiologist, to the amyloid specialist, go to the cath lab, get the biopsy done. Whereas this way, you order the labs, you order the tests within a month or so, as soon as whatever the availability for the test is, you have your diagnosis.
It doesn't seem like that procedure would be without risk either, right? This biopsy of the...
Correct. Yeah. So, I mean, in the right hands, since the heart is so thick, it's very hard to have complications. But right, it's a procedure. It has its complications. It has its inherent risks. Whereas this way, I mean, the test that we use, the PYP scan, has been around for decades.
Okay. So is there some hereditary and some non-hereditary?
Majority is wild type, so non-hereditary, and then the less common form is the variant or the hereditary.
Of course, it's got to be the wild type, right? And we don't know what caused it.
Right, exactly.
Yeah. Mm-hmm. So how are you communicating with family members of patients who test positive for hereditary ATTR CM? And how do you approach, is there monitoring that you do for these family members?
So if you look at the diagnostic algorithm, so you do the AL Royal Labs, which is the first step, then you get the PYP scan. If that's positive, there's actually one more step. So all patients who get the diagnosis then should be genotyped. Again, to see, do they have wild type or age-related ATTR CM, or is there a specific gene mutation that's led to this disease? But it's mostly for the family members. So you can do cascade screening, screen the siblings, screen the patient's relatives to see, do they also carry the gene? This then allows us to keep an eye on those patients more frequently in clinic. We'll also refer those patients to our amyloid clinic as well, just for routine monitoring. But the main reason we do that, again, not more so for the patient, but also for the family members to see, do they carry the genotype? And if so, are they at more risk to develop the phenotype later on in life? And that's where the monitor becomes crucial for those patients.
Yeah.
Okay, so just because they have the genotype doesn't mean they're necessarily going to go on to develop the cardiomyopathy.
Correct.
Exactly.
Yeah, because there's some people advocate, okay, well, let's just do a genotype first approach, where if the patient doesn't want to do the testing, let's just test for the genotype. However, that's also very rare. So even the most common mutation in the United States is what's called the V142I mutation. That's present in 3 to 4% of African Americans, but that is rare. Again, wild type is the predominant. So just simply genotyping is not the right thing to do. You have to do the full diagnostic workup.
And we do a full genetic testing for a lot of our patients, especially if they're non-ischemic and maybe we don't know the cause of their heart failure. So the ATTR genotype is included in the full panel that we get for our cardiomyopathy genetic testing. And anecdotally, we had a patient who tested positive, was put on treatment and everything, tested positive for hereditary amyloid, and actually had his brother and his children all tested, and they were able to identify two other family members who were all positive with that same genotype. The other two didn't have any symptoms, but were able to go on with serial monitoring with our general cardiology team. And so we were able to potentially catch a future patient if they were to develop symptoms down the line as well with that.
And are these genetic tests generally covered by insurance?
It depends. There's different companies that offer genetic testing. Some of them will not bill insurance at all and cover the cost of it as part of their patient access. Others will cover it with insurance using billing insurance. And the one that we use the most often, they will call the patient prior to actually running the genetic testing to confirm copay cost and making sure that the patient consents to whatever that copay might be with insurance. So it just depends on the insurance, unfortunately.
And then in our amyloid clinic, the patient actually meets with a genetic counselor who has this discussion, a full in-depth discussion. So it doesn't just come from either the pharmacist, the cardiologist. They meet with the genetic counselor, them and the family members, to go over the risks, the details of the test. And they actually find it very beneficial to have the long discussion with them.
How do you collaborate with prescribers and other healthcare professionals during this patient identification?
So in my clinic, I actually have a very close relationship with both our primary care providers who we work with and our cardiologists. We practice under a collaborative practice agreement, so that does allow me to practice rather autonomously in my clinic. So when I have a patient that I suspect may have cardiac amyloidosis, I simply will discuss that case with the clinician on site. Or if they're not on site, I'll send them a secure message in the EMR saying, hey, I think this patient may have or has those clues for cardiac amyloidosis. Are you okay with me with initiating the workup? Once that case is discussed, then I have saved order sets in the EMR for both the AL rule-out labs, which is the serum immunofixation, the urine immunofixation, and the free light chain assay, and then the PYP scan. Both of those are ordered at the same time. Then the patient will go downstairs to the lab, get the necessary tests done, and a call to schedule the PYP scan. Once those tests come back, if there's any abnormalities, I'll discuss with the collaborating physician. If there's any abnormalities in those immunofixation labs, we will also call our hematology friends to see, hey, is there anything else we need to do to make sure that AL amyloidosis is fully ruled out? Again, that is the most critical step. If you look at the most recent 2025 ACC clinical guidance statement, that's a major pitfall where a lot of providers will fail to fully exclude AL amyloidosis from ATTR CM. Then once the patient gets the necessary tests, if they are diagnosed with ATTR CM, then I will schedule an appointment with our dedicated cardiac amyloidosis clinic for the initial visit. This, in my practice, has worked out very well. And I would say about 90% of patients who go to the cardiac amyloidosis clinic for the first visit will actually have their diagnosis already established prior to stepping foot into the amyloid clinic for the first time, so that they can focus more on deciding what treatment options are best for that patient.
In addition to that, we also work on educating our primary care and echo sonographers to make sure that they know what to look for and what to identify, because sometimes general cardiology will do the echocardiograms that primary care is ordering, but then primary care will get the results and not realize the key clinical factors that they need to look for. And we've noticed a huge increase in patient referrals and even just the question of working through these patients a little bit deeper once we increase education for our other colleagues outside of the cardiology space who might be looking at this a little bit closer already. And same with educating the echosonographers. They feel more confident bringing suspicious patients up to the team, whereas they might not have had the education to do that prior.
What have you both found to be most rewarding as a clinical pharmacist helping to identify these patients with ATTR CM?
I mean, to me, the most rewarding part is that you have a direct impact in the patient's life. So you were able to identify a life-threatening disease that many clinicians miss, and then you can say to the patient, hey, we have an official diagnosis for you, and we also have multiple treatment options for you as well. which we have now shown can alter the trajectory of this disease. It's funny, one of our advanced heart failure clinicians who I work with directly has even called me the amyloid hunter because I do identify many cases that actually get referred to our amyloidosis clinic. But on a personal level, it's the fact that you have a patient referred to you, at least in my case, that comes to you for general heart failure, but then you're able to take it a step further, put your investigative hat on, put all the pieces together, and then identify a specific cause of heart failure to give that patient their actual formal diagnosis. And honestly, I get really excited when I am able to identify these cases in the clinic, especially if I can identify them early, where the benefits of all the treatment options we have are most pronounced.
Mm-hmm.
Yeah, definitely super rewarding to be able to identify those patients and also to give patients a why behind their potential symptoms that they might be having. A lot of times the HF-PEF patients tend to be a little bit more forgotten in the clinic because there's not as much literature, there's not as much data to support them. Hopefully that's changing in the future, but we've noticed that a lot of patients kind of are told, okay, this is just kind of how you have to live now. And then they don't really get any answers to circle back to. So that's something that's really rewarding to be able to help the team identify a why behind why the patient might feel like that, and then also to be able to provide medication options to help reduce their overall mortality and morbidity.
So how might a clinical pharmacist get involved if they aren't already actively identifying patients?
Well, what's unique to us is that pharmacists are everywhere, especially clinical pharmacists. Our roles are multifaceted. So I would say if you're a clinical pharmacist like myself who practices in a heart failure clinic, you really have the most frequent contact with these patients. And in my case, I'm often the provider that they see most often. So I will guarantee that some of these patients in your clinic have ATTR CM. You just have to take the time, ask appropriate questions, find the best way to navigate the EMR to look for those clues and red flags, which are present often in many of those patients, and then try to dig deeper into the patient's heart failure. And I guarantee you, you will identify patients with this disease. Having a high index of suspicion is the crucial part, as identification is actually the most difficult part. The diagnosis and the treatment are relatively straightforward. And I would say if you're a pharmacist in any other setting, the key thing to look out for are those extra cardiac clues, the orthopedic manifestations predominantly, because all you have to do is have that discussion with the clinical team. And it takes that one individual to say, hey, this patient may have amyloidosis, to get that conversation started, which honestly can be the deciding factor between the patient getting a formal diagnosis versus going undiagnosed for many, many years.
Another way that pharmacists could get involved if they have maybe a passion for it or an interest to get a little bit more clinical and they don't have an established role with like a collaborative practice agreement would be to kind of be there and be available for the providers on the back end. So after the patients have been identified, the AL rule out has been completed and they want to start therapies, there's a lot of barriers after that come up for the patients, whether that's a prior authorization, cost assessments, making sure that the patient can take the medication when they're on the medication. So being a resource that's available to providers, and it kind of takes time to build, just as anything does, building rapport with providers, finding the champion provider that maybe you want to work directly with and sharing your interests with them so that you can get involved with these patients, even if it's on the back end, not in the identification phase.
Thank you so much. I mean, this is just, I don't know, this is fascinating to me, right? I mean, a little bit scary, all the things that can go wrong with you, but like the fact that you're able to like figure this out and treat it, it's just amazing to me. All of the diagnostics and how far medicine has come in such a short time.
Yeah.
And
But you guys
patients
actually early. Yeah. So there is actually such a thing as too late for treatment.
Oh.
Yeah. So that's why catching early. And it's funny, my colleagues always make fun of me. I get super excited when I find these in clinic. It's like a little light bulb lights up, but you're like, why are you so excited about this? Like, I don't know. The disease just fascinates me. How it's just hiding there. You got to look for it.
So for the treatments that you have, do you have to have like clinical manifestations of heart failure to receive those treatments? It can't be something like prophylactic?
Yeah, so right now it's diagnosis with heart failure. There are some studies looking at like those genetic carriers to see if you add therapy before, can you prevent the onset of cardiomyopathy? But yes, you have to have the actual phenotype of disease before you can get the treatment.
And does the heart failure just occur because there's deposits where they shouldn't be and the heart doesn't beat as effectively as it should?
Yeah, it's a restricted cardiomyopathy. So those deposits get stuck in the heart, make it very stiff.
Yeah.
And over time, your cardiac output goes down, you get more and more symptoms, arrhythmias, and then ultimately, you pass away from that.
Is it kind of like, is it scardosis? What is that? Like
sarcoidosis?
Yes.
Yes.
It's one of those infiltrated cardiomyopathy where there's infiltration from a particular protein, which in this case is amyloid.
Okay. Well, thank you, Marina and Dan, for chatting with me today and sharing this valuable information. And a special thank you to Pfizer for partnering with us to bring you this information. As a reminder, NASP corporate members are invited to be my guest on one complimentary podcast per year. For more information about this or other NASP membership benefits and events, please feel free to reach out to membership@naspnet.org or visit our website at www.naspnet.org. Until next time, have a great day.